feel much like we can start. Oh, see, yeah, that's.
Okay, we are live. This is Senate Health and Welfare. And it's February 28th, hard to believe. The day before the last day of February. We've got two bills that we're voting on this morning, S-187 and S-302. And we looked at those yesterday and made some small changes, I think, important changes. So let's start with 187. And this is the bill on sunscreen application. And we've heard testimony from Sue Bogowski of School Boards Association suggesting that we change language. And we did, we took one section out, section B out. It wouldn't have the wrong group making policies for the schools. So, any discussion on that bill? Motion? I accept the motion.
I would move, that we recommend favorably draft is at 2.1
Yeah.
of S-302 to the full Senate.
To 187.
Pardon me?
187.
What?
One
I thought, oh, I'm sorry, I was on the wrong bill. 187,
Okay.
draft 2.1. I'll second the motion.
I'm a mathematician.
I second.
Okay, good. Discussion. All right. Clerk.
So we are gonna take a vote on draft 2.1 of 187.
Senator Kulik, how would you like to vote on that bill? I will vote yes. Senator Hardy.
Yes.
Senator Williams.
Yes.
Senator Weeks.
Yes.
And Chair Lyons.
Yes.
Okay, S-187 version 2.1.
I need a reporter for this one.
Go out 500.
Was it going to be for?
It would go, you would take it up today. It would be on notice tomorrow and reported Friday.
No,
Okay.
Wow.
Terrific.
You're doing the sunscreen bill? I thought,
yeah, it saved you from doing something.
What,
more
did you want to
complicated.
do it?
no, what happened with that bill that we passed yesterday? Are
$469?
you doing it?
Yeah,
Okay,
it's okay, son.
I'm just,
We got you.
Which one was?
We can see what kind of a day it is at 8 and 1. All right, so,
That was.
Ulysses.
Ulysses, yeah.
yeah, that's Ulysses. Okay, so let's move on to S-302. S-302
Okay.
is the Alzheimer's bill.
all right,
And we did make a change in that bill as well. We improved the language related to translation. So, based on testimony from Jay Green, I'm looking for the exact language that we put in. Language access services from translation services.
We're talking about 302.
302, the Alzheimer's bill, and Jay's experience was that language access services is the appropriate terminology when talking about translating for folks.
Yeah, we made a couple.
I think that was,
Well, and then we checked in on,
which one?
cultural competence.
Oh, and he, indicated cultural competency was what was appropriate given the work of the health equity group.
Okay, so I'll make a motion to pass favorably S-302 out of the.
Second.
Okay,
So,
discussion, questions? I think we're good.
Okay, Senator Kulik is a yes. Senator Hardy.
yes.
Senator Williams.
yes.
Senator Vice Chair Weeks.
Yes.
And Chair Lyons.
Yes.
Okay, we'll vote it out 500. And reporter.
I'll do this one.
Sure.
Yeah, Terry, do you want to?
Terry, did you want
Did you want to do
Okay.
it? Okay.
All right, good.
Just want to make a comment about the piston string.
Okay,
So I was all in favor. The only hesitation I had about the bill itself was the whole aerosol versus non-aerosol. I found that kind of like too far into the weeds.
yeah,
To be directing.
I think we're all feeling that way.
Okay.
But didn't we end up not?
We left it is in the initial line in the bill. It is still in there, but the bill has a bit of a ways to go, so when you present the bill upstairs, you can make that comment.
Can I just say, I'm not feeling that way. I think it's
Oh.
important that we have it non-aerosolized in there. Because we spend a lot of time in here trying to figure out how to
Fix it.
fix chemicals in various places, and why don't we just prevent them from getting into places from in the first place? And that a lot of aerosolized sunscreens have benzene and other toxic chemicals that once they get in the air in the school, they can affect everybody in there. And so I think it's important that we have non-aerosolized, and I'm happy that it's in there.
Okay, did that help?
Yeah.
We did hear that, that's
Sure.
You can express the
No, I won't.
yeah,
fevers.
I won't. I'll highlight it, but
Okay.
I won't give it a, you know,
Highlight.
okay, so, we're looking at S98 and, is it a new draft that we have
It's
up
a new
yet?
draft.
Yeah, we have a new draft up that based on discussion. Do you wanna zip through that with us and then we'll, literally zip through, go through it with us, and then we have folks in here to offer comment from PFR. And I guess Susan Barrett might be on,
Yes, Julie's.
Julia's here.
It's a draft 2.2.
All right,
It is draft 2.2. Good morning,
and
Jennifer Kirby,
yeah, go
Office
ahead.
of Legislative Counsel. This is S98 based on your last conversation and work with the board, and then there's some additional funding language in here that the board hasn't seen, so that was not part of their proposal. But as you may recall, you had sent them to make, I suggested bullet points, and then I met with them to discuss them, and then put the first part, at least of what it is. S98 is an act relating to Green Mountain Fair Board authority over prescription drug costs. And so the first section would direct the board to come up with an implementation plan for how they would do prescription drug cost regulation. So it directs the board in consultation with its own technical advisory groups and other state agencies to explore and create a framework and methodology for implementing a program to regulate the cost of prescription drugs for Vermont consumers and the healthcare system. And the board would consider options for and likely impacts of regulating the cost of prescription drugs, including the experiences of other states that have developed prescription drug affordability boards, CMS's development and operation of the Medicare Drug Price Negotiation Program, other promising federal and state strategies for lowering prescription drug costs, the board's existing authority to set rates, adopt rules, and establish technical advisory groups, the likely return on investment of the most promising program options, and the impact of implementing the program to regulate the costs of prescription drugs on other state agencies and on the private sector. Have the board providing an update in on January 15th or by January 15th of next year. And a final implementation plan by January 15th of 2026. It's planned for implementing the program to regulate the costs of prescription drugs in Vermont, and any proposals for legislative action needed to implement it to this committee and House Health Care. We would create 2 positions at the board to lead the exploration, development, and implementation of the program. 1 director of prescription drug pricing and 1 policy analyst prescription drug pricing. And we would appropriate $245,000 to the board from the Evidence-Based Education and Advertising Fund. This is a fund that is created in statute in Title 18 to collect fees from manufacturers of prescription drugs. It was initially created, and you can see where the name comes from during some work on detailing where manufacturers go to, side note, but maybe where manufacturers go to physician and other providers' offices to talk about their prescription drugs that the manufacturer is marketing. And there was some effort in the mid 2000s to start doing some academic or counter detailing to have other information provided as well. That's where the evidence-based education and advertising fund came from. Its uses have been expanded over time, all relating to prescription drugs. So there seemed to be a connection there. So $245,000 is appropriated to the board in FY25 for those positions. We would give the board legal assistance as needed from the Office of the Attorney General. And then would also appropriate $250,000 from the Evidence-Based Education and Advertising Fund in FY25 to contract with experts on prescription drug related issues to work with the board. And Nolan can tell you more about what's in the fund. You don't know what has already been obligated. But then the bill goes on to amend both the manufacturer fee and the Evidence-Based Education and Advertising Fund, where it lists the permissible uses of the fund. So in Title 33. Title 33 has the manufacturer fee requiring each manufacturer or labeler of drugs paid for by DVA for the state's health programs, Medicaid, Dr. Dinosaur, and Bee Farm to pay a fee of 1.75% of the previous calendar year's drug spending by the department. This is existing law, which is showing you the list of what the fees collected under this section can be used for. So that first one is collection and analysis of information on pharmaceutical manufacturing activities and analysis of information needed by the Attorney General's office. There's additional provisions. This would add as a use the Green Mountain Care Board's prescription drug cost regulation initiatives. And while I was in here, I updated make rules to adopt rules. And then similarly, this should be section 3, but is 33 VSA 2004A is the fund itself and has that same list of permissible uses. So I've added Green Mountain Care Board's prescription drug cost regulation initiatives. And then put a cap on the amount that monies from the fund support the board's prescription drug cost regulation initiatives shall not exceed $1 million in any one fiscal year. There are several uses for that fund, and it would take effect on July 1st, 2024.
Okay, that's good. Certainly the use of that fund relates very much to the board will be doing. So I think it's a legitimate suggestion. Okay, any questions for Jen?
Take that section for.
I'm just gonna make it count. 6. We are 1 over. We might want to open the door. And then Jessica, if you can make sure that it's okay. Oh. Now we're right on target, but when someone else comes in, we'll be over again. But we should probably have the air quality control. It's on. Yeah.
She's on.
Okay. Okay, questions for Jen on this? So Jen, the other way that the board can access funds is through bill back. Do you want to just share, can you share what that is or not?
I can, but it's really we could build this into bill back, but I think that would be a different conversation.
No, it isn't. I'm not suggesting that we would do that. I'm just saying that the board does have bill back.
Yes, the board does have the ability to bill a portion of their costs in regulating entities to the regulated entities. There's some proposed changes to that in the budget this year, so we should take a look at that.
I didn't realize that.
Coming up.
Well,
Yeah, I think there's been some consensus work on modifying the percentages a bit about how the state portion gets over.
Okay. And I do know that in H72, when we look at that, there is also language related to the manufacturer's fee on the overdose prevention centers. Okay, yes,
Just out of curiosity, is there a point when we're going to talk about return on investment for this $1 million?
we can do that.
That would be.
Yeah, the million is a cap, but right now in the bill, it's
So you're, yeah, but I think the question is,
95,000. So, yes.
will there be a benefit from what we're doing? And so that question goes to Dr. Sokol or Jean Horvath, who we've had in before, and we'll ask that question specifically, so we can get an indication of what's happening in other states. Benefits. We'll do that. Go ahead.
I'm just scrolling through there, to that point so this is basically just. Implementation plan, and so there so that could be something you add to the implementation plan that they. Report back on it after, yeah, it's in there, the
Like
likely
return
return
on
of investment
investment
is
is encouraged.
Yeah.
But I think what Senator Weeks is asking is it worth doing this in the first place? Do we have any evidence it's gonna work initially? And that was going to reach out to Maryland or.
more generically, not
Yeah.
specifically to
Yeah.
Vermont, oh, okay.
Oh, I think that's what you were asking.
It's a good place to start.
Yeah. Okay. I don't want to be real. Okay, Senator Williams.
Along that line, wouldn't that be a GFO? Did they help us with that? No.
No, this is really much more specific, and for folks who are currently engaged in it, JFO would have to go through it. We'd have to pay them to do a whole lot of it. So we'll reach out to Dr. Sokol and to Jean Horvath and get that information. Okay. Thank you.
He was shaking his head while you asked that question.
So Emily, thank you for being here.
Yes. Hi.
So, but we also have Emily Brown and Susie Barrett come in and talk about, I think the question is this the right place? And just talk about, get your thoughts. on that.
Yeah, so my name is Emily Brown. I'm the Deputy Commissioner at the Department of Financial Regulation for insurance. So I think just generally, the department supports efforts to regulate the cost of prescription drugs. We realize how much they contribute to rising healthcare costs. So, appreciate this effort. I do believe that it is, at least the last version I'm looking at, 2.2, it does make sense, I think, to have this with the Green Mountain Care Board. I think it appears that the new bill too opens the scope to look at other potential programs aside from the prescription drug affordability boards. I think in sub 3 there and other federal or state strategies for lowering drug costs. I think that's a good addition. So I think, and I can't really speak to the allocation, the amounts of, I'm not sure how much it would cost to really look into this, do the analysis. So I don't really want to speak to that. And I don't really see a role for GFR for this work. I think there is another bill that would go towards regulating PBMs, similar to how we regulate health insurance. That makes sense, but this is more of a healthcare policy, which would fall outside of the department's regulatory scope.
Do we have this in writing?
I can provide.
That would be helpful.
No problem.
Right, so, yeah, thank you. Questions for Deputy Commissioner? That was clear.
Yeah.
And that
I
was
try to get
because
concise.
the question was, should it be a DFR? And you answered that very explicitly.
Yeah, no, I don't think it should be. So we can provide our written testimony. So,
All right.
okay, thank you.
Okay, sure. Susan, welcome.
Hi, good morning. Susan Barrett, Executive Director's Agreement and Care Board. Sorry, I was a little tardy this morning. It was very fun, yeah.
Couldn't see your way.
But,
You couldn't see your way.
yeah, slowly. So we support this language. We worked, with Jen on the language. I will just reiterate that in order to do this work, we need resources. We are, I don't know, I have a number in mind. I could share that with you now, like 2 people, or do you want me to go there? Or-
Yeah,
I can send it
I
out.
know
Oh,
what
okay,
you're
great.
thinking. I know
so-
that initially you had said 5 people, 5 positions and $500,000. And what we have done in this draft is trying to narrow down the initial work. And then I looked at the fund as a source of money, so we could reduce the general fund obligation. So
Yes,
what you're
Yeah.
thinking is initially and then going forward.
yes, so initially, in terms of resources, we would need 2 full-time positions. One would be a higher level director position. This is work that we do not have anyone on staff. We have a brilliant staff at the Green Mountain Care Board, but we do not have expertise in this area currently. We did also put in a request for approximately $250,000 for contract resources. Again, it's a new area for us. We want to look, working with other folks who may have been working with other states to learn from their experiences. So we can be successful at this work. But that is my strong recommendation, is that in order to be successful in this work, we do the work before us, we would need those resources.
And the timeline, because there's a timeline in there for January 25 and then ongoing.
Yeah, so to really set up what, and I hate to use the word study because it can mean different things to different people. Evaluate, explore, consider options for an affordability program that works well for Vermont and for Vermonters and for the Green Mountain Care Board. And does the work at the most affordable cost. We don't want to, we feel like this is a right size for the amount of work before us. And then we will come back and report to you on what we've learned and our recommendations. And then I believe it's 2026.
Questions? Susan? So, I mean, obviously, we'll look at the bill. We'll go through for markup purposes. And the big step, of course, is ensuring that we have the resources to do this work should we decide this is, well, I think we have all talked about how important it is to regulate prescription drug costs, but to make sure that this is the time that we can do it cost effectively. Senator Williams and then Senator Gould.
What was the 2026 date that you just mentioned?
That would be, and I'm looking to Jen, because I don't have the language in front of me, when we actually start doing the work, correct?
So that's when you come back with the implementation plan.
Plan,
Yeah.
implementing.
Do you foresee the 2 positions remaining, or they just really get the program off the ground, getting started?
They would have to remain. We don't have people, we don't have enough people to do the work we have before us now. Leading such a large part of the healthcare system, that this on top of it would mean, if we continue this work, we need the people to actually do the work. And the board will do some of the work, but the board, with all of our work, there's the staff. But I'm here today, some previous people who this work, who are really in the trenches, preparing all the information and informing board so that they can make the best decisions for Vermonters. So that, yes, I would foresee continuing these positions.
Great. Yeah, we did hear testimony a while back from those 2 women who were fabulous, and they reiterated how complicated and complex this work is, but also how it pays dividends in the end. So,
And we'll have her back.
Yeah.
So for that. So, good, I mean. The good news is that other states are a step or two ahead of us, so
Right.
there's some information that's available. And then also for the work, once it's implemented, there will be partners out there.
And we've already talked with many.
Yeah.
And Julia
Julie's
has done a lot of like work on that, but she also has another job, several other jobs. We all have, wear many hats.
But once you see this, you get so excited about it.
Well, we agree with the purpose too. I'll just reiterate
Yeah.
that. We see the impact of the high cost of prescription drugs on all of our regulatory work and the impact on Vermonters. And we want to try to address that.
Okay. Other questions at this point? Perfect. Good. Thank you so much. Thanks for being. So we'll put S98 up. It's not up the rest of the week, actually. We'll put that bill up when we get back after town meeting. And, try to get to a good place. We'll have Dr. Sokol and Jane Horvath in for testimony. And then we'll try to go through, assuming that they say good things. We'll go through and do some markup and maybe pass the bill out. Okay, so we are on S-151, and for this bill, just like, we're early. I think we're okay to start early. Usual. If we could have started 15 minutes later, then we wouldn't have had to be here. Okay,
Well, we-
my fault.
That you talked about us.
I did.
Well,
We started early and are being efficient.
we're being too efficient. Okay, so, Jen, we have some language in the bill that's new, and I think it could probably be helpful to look at that. And so here's what I want to say about the bill, S-151, it was put in last year. There are some ideas and language in that is old. I understand that. I think all of us, we do understand that. But then we also know that, thank you, Emily. Do you mind leaving the door open? It's a fun, it's such a big deal.
Yeah.
Let's just let it air out.
Oxygen.
We open that window?
Can we open the window?
No,
Storm's closed.
yeah. Oh, leave the door open, please.
Oh, we're getting air.
Oh, you guys are going, okay.
So what I would like to say about some of the language in here is, as I have said before, I asked folks to come together to talk about the AHEAD model, because I understand that if AHEAD is the direction that the state is going to take, then certain things have to happen. And the Agency of Human Services and the Greenhouse Care Board, or the agency really, in its negotiations with the federal government, with CMS, is going to need a platform on which to negotiate. And we need to know, as a legislature and as citizens of the state, what is going to happen, what may happen. So there are also concerns expressed about the AHEAD model and whether it's the right thing for the state. But we won't know that, and we can't know it until we have the information that we would get through the negotiating process. There are certain things within the AHEAD model that we will hear about when we hear from Pat Gilman. I think we have her coming tomorrow. Yeah, so when we hear from her about what is happening with AHEAD, we had her in. What are the sort of the concrete pieces that are so critical to moving ahead? For me, there are some things that are very important. We can't do this with a minimal amount of resources. We can't be expected to continue to function as a state as a low spend state. We can't do that. We need help from the federal government. So I'll just say that once. There are other things in here that are important considerations that hospitals are concerned about, Agency of Human Services is concerned about, Green Mountain Care Board is concerned about, providers are concerned about. So I asked those folks to meet separately and to come up with some language that could, and also Mike Fisher, our care advocate, and our insurers, ask them all to get together and to come up with some language that they could live with. And so we will hear from folks who are concerned about the languages in the bill or would like to see modifications. So this is the first step. The biggest new piece in the bill is that ahead piece. And then there are other sections of the bill that we've talked about previously that we will also look at going forward and hear testimony about. That's it. So Jen, I'll just ask you to go through, please. And people are not around this week because the kids are out of school. And we've had people who are leaving, so I think there was a request to be here today, so we're doing that early. So there's no preference given to people testifying first, I want to say that. So we're just trying to learn, okay, not trying to do anything else here.
Thank you. In what level of detail do you just want me to flag the new sections?
Yeah, let's do that. You can go through all the sections, and certainly there's one section that we've heard about already that people are very concerned about. I think it's section 4. Yeah, so we'll go. I mean, if you can go through and remind us what's there, then when we go through the bill in more detail, you'll make changes, however, but the new language.
Okay, that's okay. Jen Carney, legislative counsel. We're looking at S-151, enacting the pay parity and transparency in healthcare. So I have, as usual, when I bring you new drafts, I've done some markup to show you what has changed. So section 1 has not changed. This is the piece on the health insurance rate filings, and having the insurers provide the amount total premium revenue expended on care coordination and management. Section 2 has also not changed. This would make a change in the coverage trigger for colorectal cancer screening. There's also a bill upstairs that is looking at a different approach to this same issue. So we'll make sure those are coordinated. Section 3 is proposed for deletion here. This is it's first it's voluntary, and if not, it's required provision around insurers participating in the state's agreement with CMMI to participate in multi-payer alternative payment models. There's some intent language on this later. Section 4 we have looked at and have not changed. This is around minor consent to prevention of a sexually transmitted infection. And section 5 is the conforming revision provision, which we may need to look at in a little more detail. We may need to make some additional changes than just swapping terms. Section 6 is the annual reporting by insurers, and this requires them to report on their risk-based capital reports. Basically, it's the solvency, I think. Is that what this one is? The risk-based capital report solvency?
It's about solvency.
Yeah, great.
But-
Thank you.
And I'm sure you have concerns about that language.
Section 7, and it also does not change. This is the language on increasing primary care spending allocations to 12% or more. Section 8 is making changes to the purpose statement for the Green Mountain Care Board. Has not changed. Also did not change the provisions around the nomination and appointment. Those changes that are proposed for the Green Mountain Care Board members. Except to add, the editors noted that there were no, that most of the subsections, this is sort of in the weeds of drafting, but most of the subsections had subsection headings, but these two new ones, those 2 and D and E did not, so. Putting in some being consistent throughout. All right, now we get to some new stuff. This is new to the bill, but not a new topic because we looked at it in S-211. This is the provision requiring mediation by the Green Mountain Care Board prior to termination of a contract between a provider and a health plan. with non-binding mediation results.
we did hear testimony from, Owen Foster, I think, that was okay. Wasn't any enthusiasm about it, but, okay, but we can circle back to that.
Do they have mediation services? I don't know. If that's something they do.
So that's why we'll circle back. I think he was fine.
8B is new. So this is new to the bill and does not come from anywhere else. This is in the hospital budget review subchapter. And the board's duties, and this would add a duty to develop a methodology for establishing hospital global budgets. There may be other changes we want to make along with that, but as to be a place to start. Then we go on to section 9, which was the hospital budget review statutes. We had looked at potentially a timing change. This keeps the same timing, but also puts in the study on looking at the timing of all of the regulatory processes to see if those should change. This
That's
puts
a big deal, but okay.
right, so you'll see that coming
Yeah,
later.
okay.
That study. This is some new language from new to the bill, but taken from S211. In the existing law, it allows the board to establish a process to define on an annual basis criteria for hospitals to meet, such as utilization and inflation benchmarks. This adds the S211 language saying that any such criteria or benchmarks must be set at the hospital level or across the healthcare system and not at an individual cost center or service level, directing the board to consult with stakeholders before establishing any of those criteria or benchmarks, having them established not later than March 31st annually, and not adjusting or amending them during the budget process, except by mutual agreement of the affected parties. Section 10 is unchanged from prior draft. This is requiring the Department of Labor to update at least biennially its schedule of rates and fees for workers' compensation healthcare services. Section 11 is also not changed around some Medicare provider rate information and talking about an intent that the healthcare system reimburse all Medicaid participating providers at least 100% of the Medicare rates, and having DVA either provide those rates in its budget proposal or say how much it would cost to reach that. It just flagged here that this is still tying it to calendar year 2022. I'm not sure if that is the intent, so I wanted to make sure we didn't lose track of that date. Section 11A is new, and I will probably renumber the whole thing when we're done, but for now, I'm just putting things in at A and B. So this is legislative intent on the AHEAD model. So there's a lot of intent in here in several different subsections. It starts by saying it is the intent of the General Assembly that the state apply for and consider participating in the AHEAD model with the Centers for Medicare and Medicaid Services, which includes hospital global budgets, increased investment in primary care, continued investment in SNASH, and improvements in health equity. If the state is selected, it is the intent of the General Assembly that the state participate beginning on January 1st, 2026, as long as the model is determined to be beneficial in addressing the state's goals of improving affordability, access to care, quality of care, health equity, and hospital sustainability.
So Senator Gulick has a question. I think we'll go slowly through this because
Yeah, does this language mean that if we are selected, that we are bound to accept the model?
No, it says if we're selected, it is, first of all, legislative intent that we would participate as long as it's determined to be beneficial in addressing all of these things. So if it's not determined to be beneficial in addressing those things, it is not the intent of the General Assembly that the state participate. So all of this is an intent which is not binding.
What would that look like? I mean, who's gonna determine its benefit or non-benefit, and is there, sorry,
good question.
Yeah.
And that's exactly what we have to grapple with.
okay, yeah.
Senator,
Why have that language in here? Is it all?
I don't think you can determine what the AHEAD model will mean until after we understand what we might gain or lose from it. So that is exactly why Pat Jones will be coming in tomorrow morning. Some of these questions we've been asking for.
I do think you'll hear from some other witnesses, but I do think there is, whether it's required or appreciated at the federal level to understand that there is, whether there is legislative backing behind the state's pursuit of participation in the model. So this is expressing legislative intent, although there is not an active role for the legislature in applying for or signing on to.
We also can establish conditions and criteria for making the decision.
Right, yep, and you certainly, when the state went ahead with the all-payer model, there were certain conditions that were placed in the legislation. We were probably only go ahead if these conditions are met. I don't know how this model compares with what we're pursuing on that. All right, goes on to say it is the intent of the General Assembly that global hospital budgets include the participation of all major payers and insurers and of Vermont hospitals, and that the budgets will be sustainable for all types of hospitals in the state with the goal of improving affordability, accessibility, and quality of care for Vermonters. Goes on to say to the intent of the General Assembly that any agreement entered into between the state and the federal government for Vermont's participation. It's getting out to open it. I know she just keeps getting this.
Also, dance, I'm getting for people to be quiet.
When it gets hot, we'll open it again.
So it is the intent that any agreement entered into between the state and the federal government for Vermont's participation in the model first acknowledge the decades of successful
Can you go back to that sentence, go back to that introduction on C, please?
Yes, this is starting to get at it is the intent that if you enter into it, here are the things that would be involved. So first, that it acknowledge the decades of successful implementation of payment reform initiatives that have made Vermont one of the lowest Medicare spending states, despite having one of the oldest populations, by investing in primary care, integration of health and human services, SASH, the rural health system, and critical hospital transformation efforts. Keep going.
Seems like an odd paragraph, just kind of pat yourself on the back, doesn't really say anything.
Okay.
It's kind of an unusual paragraph.
Well, but here's if you take that unusual paragraph, I'm trying to figure out, what does that mean? It might mean that we've been doing this on a shoestring. I would say that later. We've been doing this without a high level of investment from the federal government. And in order for us to continue with this type of program, we would request more than the $12 million that HED is promised. That's the way I look at that, to use that as leverage. And perhaps with language we need to put in there that suggests that the federal government has not been forthcoming resources as they should. And one of the things that I've got there.
Smacks more of a war speech than a bill. Not really.
Yeah.
Yeah, so I think you'll want to hear from other
Gotta hear
witnesses who
from
may have had a role in proposing some of this language to see if there are particular reasons that they are putting this language forward.
This is legislative intent written by people who are not legislators, which I find incredibly odd and results in language like this.
Well, sometimes we reach out to have multiple parties get to an agreement so that we can move ahead. That's not a pun. So let's keep looking at this. Let's keep going.
Okay, so again, the intent that any agreement accounts for the savings generated by these initiatives to achieve the sustainability of the rural healthcare system and acknowledges the continued cost to the system due to ongoing pressures from the global COVID-19 pandemic and healthcare inflation, including the increased costs of staffing to meet workforce needs by ensuring a model that creates transparent and sustainable payments to providers. And then finally, it is the intent of the General Assembly that the administration and Fremont Care Board, in their negotiations and plan for the HED model with the feds, identify any necessary modifications to the regulatory structures in Vermont law and recommend those changes to the General Assembly in a timely manner in order to have them considered prior to the model's implementation.
Should the model be implemented?
Right, this is in their negotiations and plan. All right, section 12 has the Green Mountain Care Board. This language was in a previous draft, but it's added to here. Collecting and reviewing a representative sample of healthcare contracts and fee schedules to form the board's development of a methodology for increasing transparency around healthcare contracts. This would add that the board shall examine reimbursement rates for different types of healthcare professionals, including primary care providers, physical therapists, and other allied health professionals, and identify opportunities to modify reimbursement rates in a manner that increases equity across healthcare providers and healthcare settings. That information provided by January 15th, 2025. So first, that proposed methodology for increasing the transparency around healthcare contracts, recommendations for legislative action, and also new language would have the board recommend ways to create greater equity in reimbursement rates across providers and settings. Section 12B is new to this bill, but pulled over from S211. This is the piece I was mentioning earlier, would have the board in consultation with the Director of Healthcare Reform evaluate realignment of the timing of the board's regulatory processes. Building and expanding on board's regulatory alignment efforts could consider alternative models like multi-year budget reviews, multi-year financial stability audits, and other regulatory processes that achieve the state's goals of improving the health of the population and reducing per capita rate of cost growth while ensuring access to and quality of care. The findings and recommendations by January 15th, 2022.
So what I would say is this was happening before it became a discussion. I'm not sure the board can do all of this right there. Not do by 45. It's a nice idea. This is like piling. So already looking at hospital transformation, local budgets, and how we hit might be.
And then the act would take effect on July 1st.
Okay. There's a lot in there, some of those things, one of the things that we do want to take testimony, and I think will be helpful going forward, is the nominating process in particular, and as I said, we'll get the chair of the nominating committee and talk a little bit about that. And the board, of course.
So are we combining S211 in
No.
151?
No, there are things that have been taken out of 211. We also took things out of 151. Yeah, we're building.
Can we go back to section 5?
You want to go back to section 4, I think.
Section,
Yeah,
okay.
we can do that. We do have someone scheduled for
Okay.
testimony on the bill, and I know that there are others who have reached out to testify in the bill who will have comments on section 4, so it's not that there are a number of people who will target individual sections, and I understand and respect that, so we need to get folks in. Jen, questions for Jen? All right, thank you. So Devin, you're here.
Mhm.
And as I said before, this, thought we would have more fuller testimony tomorrow, and because of vacation, things change.
Jeff Green, Vermont Association of Hospitals and Healthcare and Health Systems. Thank you for having me here today. I will never buy a plane ticket in November for travel to see my mom at this year again.
Good.
But thank you for having me, and I do want to say I really appreciate the work that's been done on this bill. I know a lot of folks have been questioning the need for it and why are we doing that? And it's hard, and I hear that. And what I'd like to say is just walk you through a little bit of where we were with the LPR model.
Senator Williams.
I'm sorry.
Thank you.
And why this bill is important for us today. So back with the all-payer model, that was shifting healthcare providers and particularly hospitals to value-based care away from fee-for-service. We're still very dedicated to going to value-based care. We are still very interested in global budgets. We don't want to go back to fee-for-service. That being said, fee-for-service is something that we know and it's predictable to us. And this holds a lot of unpredictability in it and a lot of risk for hospitals. Back when we did the all-payer model, there was $209 million set aside by the federal government in the agreements. And hospitals appreciated that the federal government and the state of Vermont acknowledged that shifting from fee-for-service to a whole different delivery system was going to take a lot of resources and work. Vermont drew down a fraction of that $209 million. Hospitals continued to fund Blueprint, to fund SASH, and to participate in value-based care. We want to participate in it going forward, but we don't have the same cushion that we had last time to figure out the details. Yeah. We want to figure out the details now, what we're getting into now, and what is happening on the ground, and create an environment where people understand the role, people understand predictability, people understand the benchmark going forward. So I was short.
Can you speak to why more of that money why we didn't draw down more of that money?
Because it has to be matched by state funds and we didn't do that. So, so again, hospitals want to move forward. This does take funding, and it's not just the work. There's an incredible amount of work involved. It's not just changing our budgets. It's not just saying, oh, I have a lump sum instead of fee for service, and that's it. The whole point of the model is to change how you do healthcare. It's to spend a longer time with your patients. It's to develop primary care programs. It's to look at substance use programs in your community. In doing those things, changing provider behavior, I know folks have some experience in the provider world here, is incredibly difficult and takes training and takes resources and data and communication. If you look at Ticonderoga, which is in New York, it was a failing hospital. That was changed to a primary care campus. And it wasn't done by just changing it to a primary care campus. It took $17 million in state investment to do that work. You don't just turn off lights for one service over here and you start saving money. You have to invest in a new way to provide care. And so we know that there's no $209 million available here. That's gone, that's passed. But again, there's an incredible amount of risk to hospitals. There's about 3 layers of risk. One is for our own hospital budget. We get a lump sum, and within certain parameters, if we don't make that budget, we hold all the risk. So if it costs more, that's on us. The second piece is there's a statewide total cost of care for the Medicare A and B services in Vermont. I could get that wrong. I'm not sure what's in the total cost of care off the top of my head, but if we don't meet that total cost of care, the only lever to meet it is through hospital budgets. So hospitals will get cut if we don't meet that statewide goal. So that's another layer of risk for hospitals. Third, for hospitals that go in right away, there's a 1% transformation sort of bonus for them. If that program doesn't work for them, that gets clawed back by the federal government and they will owe that money. So there are several layers of risk here, and that's why we're really trying to define things now and set up a little bit more certainty going forward and work together to have shared goals going forward in this. So we think, everyone's saying it's intent language, it doesn't mean anything. I think it is, I think 11A is an important signal to the federal government of Vermont has not only not drawn down the resources that you set aside in 209 million, we've actually saved you hundreds of millions of dollars in Medicare funding. And we're a low-cost Medicare state. And so what can the federal government do in pure federal dollars to help make that up and help us going forward in doing this effort? So I think that's a very strong signal to them. And I think it also sets up a strong signal for, we need to figure out the regulatory process. Act 167 laid out global hospital budgets as AHS, leading on global hospital budgets with the Green Mountain Care Board.
You're not talking about regulation now, you're talking about creation.
Development.
Thank you. Yep.
Yes. So in the development of global hospital budgets, the AHS had the lead on that. Green Mountain Care Board would be consulted on that. And we would say for section 8A, which has the Green Mountain Care Board developing global hospital budgets, we have a lot of concerns there. We know we're not getting out of regulation. That isn't the point of this. We know that we're a highly regulated state. We know that the Green Mountain Care Board does the regulation. What we need to do is define the roles. AHS has developed budgets in the past. They've done value-based care budgets for Medicaid for hospitals. They've done value-based budgets for mental health providers, the DAs. And so they actually have experience in developing budgets. They're heading up the current technical advisory groups to develop the methodologies. So to spin this back on the Green Mountain Care Board being the one developing the budgets really reverses the process that we already have in place. We get that the Green Mountain Care Board is going to regulate our global budgets in some capacity, but we don't think they should be developing the budgets. They don't have experience developing the budgets, and quite frankly, the work that they're doing in the current.
I think Katie needs. Sorry.
Can you tell me which language are you specifically referring to?
8A.
And you'll get this in writing from you?
Yes.
Okay.
Oh, page 10, I was.
Sorry, it's not, I think in sections. I wanted to hit the high points. I would love a chance to go through section by section.
Well, you
but
will.
do
I mean,
want to-
we're accommodating your schedule, but I think that there's gonna be a lot of testimony on this from, Green Mountain Care Board, agency for services, insurance companies, hospitals, healthcare advocate, and other interested parties. This is great.
Yeah, I just think going forward for this, the goals need to be clear, the roles need to be clear. And we do need to be on the same page, to really make this work. This is a tremendous, risk to hospitals, and we do want to make it work. It will just change a lot when it comes to changing care.
Okay, and you'll get this to us in writing, so we can put it on the page.
And happy to answer any questions.
But I think what we'll do is we'll put you on after, if there are questions now. When we have your written testimony, it'll be easier to drill down. And mention specific, as you're going through, to mention those specific sections that you're talking about. And then the risk, the 3 levels of risk.
So I hear you about the unknown. I think when you apply for something new, there's always unknown. I think that the language that's allegedly agreed to in the bill, and it was a private behind closed doors process that none of us at the table except for the chair were involved in. So this is the first time.
Okay, I want to correct you, Senator. I was not involved in the
Okay.
discussions. I brought those folks together because there was disagreement,
Okay,
complete disagreement about how to proceed on this. And so I took leadership and
Alright.
bringing people together to have a conversation so that when we got folks in this room, it would ameliorate the effect of trying for us to do something that only the people outside this body can do. So you can continue.
It was a private conversation behind closed doors that this language was agreed on.
I don't know if
just-
it happened behind closed doors.
Well,
You'll have to
whatever,
ask them.
all I'm trying to say is, I don't understand why we would put this intent language in the bill before we apply for the head model. I mean, usually what you do is you apply for something and then you decide whether you wanna do it based on the terms of what that, what the thing is. So whether it's applying for a job or applying for a grant program, you see what the terms are and then you decide whether you're gonna do it. And this seems to be cart before the horse kind of situation where, I mean, I understand you feel like there's uncertainty, but this isn't gonna help you with your uncertainty. There's still gonna be uncertainty. The big thing is trying to figure out what happens after we've applied.
I think the certainty it provides, so one, I do think it's a strong signal to the federal government to say. You need to consider federal funding. There's not a lot of lines to talk to the federal government right now. Because we're still in the process to apply, and I think they do appreciate signals from the legislature to say. These sort of resource needs will need to be met for us to go forward.
But that's not what this language says. This
It
language
says, here's the money that we paid
super
you.
vague. It doesn't actually, it just says,
Let's,
Okay, but I wanna continue with what else I'm saying. The other piece that is helpful to us is it says that the Green Mountain Care Board and AHS will move forward with figuring out a regulatory process for setting global budgets. And again, that comes to that piece of both development and regulation. And so what we need there is not a process where we have a technical assistance group that's been working for over a year to develop a global budget, and then the Green Mountain Care Board comes in and changes it. But we need the ability for that technical assistance group to keep moving along and developing that budget, and then we also figure out how those will be regulated going forward as well.
but none of that is what this intent language says. What the intent language is vague and also. Again, putting the cart before the horse, and everybody's gonna interpret it in a different way. And I sincerely don't understand why this is necessary or how it even vaguely meets your goals.
so what I'm gonna suggest is, this is a
I'm
question.
going to speak with you.
Yeah, this is a good question for Pat Jones when she comes in, as well as others who will be testifying on this. I think we have a piece of the picture, we have one perspective right now and what this means. The issue is, what does the federal government need to hear from the state? Should we go forward with this? It's called intent language. I see it actually as stronger than intent. This is what we will do, and this is how we will proceed. So the word intent maybe is, for me, a little bit soft, because it does obligate, as you read that language, it obligates parties to participate. That's the concern that we need to keep in mind. Senator Bullock, you have a question?
No, I'm just ruminating on some thoughts that I might share later.
Okay, we're fine.
Right now.
Okay, so, Devin, thank you for being available today, and as we go forward, I'm sure we'll be hearing from you again, but having your testimony in writing would be helpful. You've heard Senator Hardy's concern that, this doesn't do anything for us, so we would like to know in some way how it might help hospitals from your perspective.
Great, thank you.
So we are shifting gears. And we're gonna move on to. We'll take a break and let 151 leave the room. Thank you. Katie's here, she's got a whole bunch of stuff working, and we have. Thank you for telling. You also have 192 for us?
I do.
Yeah, so I'm wondering if we should do that first.
Okay.
And then we'll move on to 186. And for folks who are up on Zoom, we'll probably do as, we're not on break. We're not on break. Okay, so Katie, we'll do 192.
Okay. Do you have that first? Yeah, okay.
Start by,
I think we should shut the door and let the air is clear.
Okay. Morning, Katie McLean, Office of Legislative Counsel. Maybe I will just start by, well, Kiki's posting the document, telling you what the document is. So yesterday, the committee looked at an amendment to S-192. There were 2 instances of amendment. Those 2 instances have not changed. But as I was putting together a section by section summary, yesterday afternoon, I was looking back at the section by section summary I put together last year, and I realized that bill, S-89 from last year, had a section directing the court how to make an order of involuntary medication. And that section was not in S-192. So I went back and forth with DMH a bit about their thoughts. They could recollect why it had been taken out. Neither of us could. And in the end, we both came full circle that the language should be in the bill. So I've pulled the language from S-89 that you looked at last year around an order for voluntary medication and added it as a new section into S-192. So that is the amendment. Yesterday, 4 senators said they wanted to join on the amendment, and I didn't end up putting anyone's name except Senator Lyons on the amendment because I wanted everyone to have a chance to see that there's a new instance of amendment first. So is it up, Kiki?
Yeah.
Okay, let me refresh and I'll. Thank you.
So, and just FYI, I haven't taken the S-192 proposal amendment upstairs yet, so it's a good catch.
Yes, I'm happy that you had not brought it upstairs yet.
Yes, good thing. And we were waiting for votes, but now that we've waited for votes, we've identified something additional that needs to go in.
Yeah, my heater's broken. Okay. So here's the amendment, the first.
No, you want it open.
Oh, you want it open?
It's like, is it drawn?
It's 3.1.
You know you
This
like
is
it.
this is the same amendment from yesterday. This is a new instance. So the first instance of amendment and the third instance of amendment are what you looked at yesterday. Those have not changed. As I was saying, I was putting together the section by section summary yesterday afternoon. And I was looking back over last year's section by section summary for S-89. And there was a section in S-89 about how the court would make its order for involuntary medication. And that is not in S-192. So I emailed back and forth with Karen Barber to see what her thoughts were, why, if she had a recollection as to why we had pulled it out. She did not, and I think in the end, we ended up at the same place that the language should be in S-192. So this is taking a section that was in S-89 and putting it in S-192.
Now you have it, it's draft 3.1, a proposal amendment to S-192. And so it includes what we did yesterday with that amendment and adds this section.
It's just the second. It's the second instance of amendment. So you looked at the first
It's in
instance.
today's folder, sorry. I don't see it.
You might have to refresh this.
Refresh.
You just posted it.
Okay. Thank you.
Yep.
One change.
Okay, so first instance of amendment, no change from yesterday. Second instance of amendment, page 5. So we're adding in a new section 8A. And this section pertains to court findings on when there's an application for voluntary medication in a mental health context. So this new language says that for a person who's receiving treatment pursuant to an order of non-hospitalization at a forensic facility, if the court finds that without an order for involuntary medication, there is a substantial probability that the person would continue to refuse medication and as a result would pose a danger of harm to self or others, the court may order administration of involuntary medications at a forensic facility for up to 90 days. Unless the court finds that an order is necessary for a longer period of time. An order for involuntary medication pursuant to this subsection shall not be longer than the duration of the current order of non-hospitalization. If at any time the treating psychiatrist finds that the person who is subject to an order for involuntary medication becomes competent, the order is no longer in effect. So this tracks a lot of the other language in this section on involuntary medication, but this makes it clear that this is specific to an order for somebody who is at a forensic facility. And then section 3 is the technical change that we talked about yesterday with regard to Dale.
Okay. Okay,
So what's the process here? You voted out the,
we didn't finish the vote, it's not really a vote, it's really, do you want to sign on to this proposed amendment? And so we can't do a committee amendment after the bill is gone. And so Katie's drafted it under my name, but I welcome anyone else on the committee to sign on. That's all. So this is about involuntary treatment for non-hospitalization in a forensic facility if the person continues to be
again, the intent is that we vote on it today or?
I'd like to have it so that when I present to appropriations, I did share the other proposal yesterday with judiciary, and they were mostly interested in notice to the victims. But this corrects it as piece that was again. So let's do this. Let's move on to the next bill, and then we'll come back to this at the end. And if you want to sign on to it, you can do that.
Can I ask a question?
Yeah, sure.
Can you explain again why you think this is necessary? I'm just.
So the language in the bill, we talked about how we create a new subsection in the involuntary medication that creates a new situation in which the commissioner can apply or submit an application for involuntary medication. But we don't have the corresponding piece that is, okay, the court has received an application, what do they do with it? So this is the instructions for the court that they can receive this application, the basis on which they're making a decision, and that they can make an order for how long they can make an order.
Okay, so this is not the order of, there's so many different kinds of orders.
It's not commitment.
It's not the commitment order, it's not the placement in forensic facility, it's just about the
Involuntary medication.
voluntary medication. And this is, obviously, this is not current law because we were adding it, but what happens now?
There is language, I can send you the section, it's a big section. But there is language in statute now about the court ordering, when somebody is in a hospital setting, the process for ordering involuntary medication. There's also language that says, even if somebody's on an ONH out in the community, and they need involuntary medication, a court can order to have the person pulled into a hospital for the administration of involuntary,
Order of non-hospitalization.
Oh, I'm sorry.
Yes, so even if somebody's an order of non-hospitalization out in the community, there's language in statute now that says, that the commissioner can seek to have the court make an order to pull the person into a hospital for the administration of voluntary medications.
So this is necessary because there's not language more specific to a forensic facility with,
Involuntary medication,
involuntary,
yes.
okay, that's, yeah, thank you.
Do you want the whole section?
I don't need it, I was just trying to figure out how it fits into what, all of it. Thank
But,
you.
Yeah, and the interesting thing is how hard we worked a few sessions ago on the O and H. Involuntary medication. There. So do this, think about whether you'd like to sign on or not, and then, we'll go on to S-186 right now.
Okay.
If you know you want to sign on, just let Katie know, let me know. Okay. But by the end of, I think, meeting today, it would be good to have that. All right, so let's move on to 186. And do we have with us Kelly Dougherty and our deputy commissioner, and we also have Jeff Rowe, director of Vermont Alliance for Recovery Residences. I met yesterday with Kelly Dougherty and also Monica Buck about the language. I'm going to suggest that we hear from Jeff Moreau first. Katie, is there anything new for 186 of this that hasn't been changed yet? So let's go to Jeff Moreau, and then we'll go to Deputy Commissioner Dougherty. So welcome, Jeff. Thanks for being here.
Thank you, Chair Lyons. Is there specific areas that you would like me to touch on this morning?
Well, you've given us a pretty comprehensive set of testimony, and it would be helpful, I think, to run through the two slides that you have. You can talk about NAR standards, but that may come up as we go forward. And then, you've got landlord tenant law handout. We probably won't be dealing with that in this committee. Others may be. It will be a good reference for us. And then you've given us the budget handout, and what I'm going to suggest is you hold that one until we go through our budget work. And here, we're going to be, our committee will be looking at what's in the budget once it comes over from the House as it relates to us. So that will be good. So if you could talk a little bit about recovery residences and the continuum of recovery, and then NAR, that would be very helpful.
Certainly, I'd be happy to. Thank you for that. Prior to 2019, Vermont didn't have any level of oversight or certification of recovery residences. A small group did receive funding, I believe, from the health department, but there wasn't a real structure in terms of oversight and best practices. So a group of individuals that really wanted to raise the bar found the National Alliance for Recovery Residences, and the Vermont affiliate, which I'm the executive director of, was created. And so just by way of background, I have been a surveyor with the Commission on Accreditation of Rehabilitation Facilities for over 15 years. I was responsible for our accreditation with CARF at Northwestern Counseling and Support Services. So I bring a strong background in overseeing these types of facilities. And so what we've really attempted to do is to work with organizations that wanted to achieve that certification through NAR and these best practices. Senator Lyons, would it be possible to have your assistant put up the first slide that you referenced, and I can go through these with you folks?
Sure. Can you do that? there's only 2 slides here.
So while she's pulling that up, NAR has a. Sorry.
Jeff, it might be helpful to have your brief comments about your experience with NAR and CAR. And your interest in establishing best practice and outcomes in writing.
Certainly, I'd be happy to send you a follow-up to today's testimony. So I'll keep going while the slides are being pulled up. So as you know, currently we have 13 homes that are certified that meet these standards. We have 3 more that are coming on board.
Okay, we have the first slide up. We have the first slide up.
Excellent. If it wouldn't be too much trouble, let's go to page 2 to start with.
Oh, they probably don't.
He doesn't. So this is.
Is everybody able to see this?
Yes.
Very good. So NAR has a whole set of standards, which I've also sent along for your review. And we certify these homes based on 4 levels. And this is incredibly important to understand what the landscape looks like here in Vermont. The first level 1 is solely pure run. And so the best example of this is Oxford House. There is a women's Oxford House in Burlington, and they've expressed interest in becoming certified. So we're hoping they'll come on board eventually. But they would fall into level 1. Level 2 is a program that has a part-time house manager that is checking in on a regular basis, orienting people to the program, dealing with any challenges in the home. And the best example of this is Vermont Foundation of Recovery. This is the model that they utilize. Level 3 is very similar to Jenna's Promise. So as you all know, you're very familiar with their program. They have more than recovery housing. They the most important thing that gets them to level 3 is their relationship to intensive outpatient treatment. And so while level 2 is referring individuals out to services in the community, level 3 is providing them right there on site. That's really the difference. And we don't have any level 4 providers currently in Vermont, but this would be similar to what we're seeing in Rutland with the step down program that has just been developed there. They're slightly higher than a level 4 on the ASAM standards, so I'm not sure that program will become certified. So in essence, in Vermont, the recovery residence landscape is really in the level 2 and level 3 area for certification. And if we could go back to the first page of this PDF, you can see that individuals can enter a recovery home in any one of these levels, but in an ideal situation, we would have enough of this resource that people would come out of residential treatment and they would scale down the various levels. And that would help them to achieve the best chance of long-term recovery because they'd have those types of supports all the way through. As you can imagine, level 4 and level 3 is really intensive work on the individual to build that recovery capital, understand the disease, begin to, really work on what has caused that, whether it's trauma or environment. And when you get to level 2, you've got some pretty good recovery capital, but you're still expected to attend meetings on a regular basis. You're expected to be employed or going back to school to continue your education. And in all these environments, you're living in a place that has peers that support one another and provide a substance-free and alcohol-free environment. So that's kind of a broad painting of the levels of certification across the state. I've spoken at length about the need for recovery residences in the sense that we have made a decision that our treatment model is 2 weeks, and that individuals will continue their recovery in their community. And so recovery residences provide that continuation. And for most people, going back to the environment that's fueled their addiction becomes incredibly counterproductive. So if we're really dedicated to having that continuum of services, recovery residences are critical. And as I've talked about before, we had the Downstreet Housing Report, and we were making incredible headway in expanding this resource across the state and getting a lot of attention around it. And as you all know, COVID happened. So that has closed some homes. We're slowly ramping back up, but funding and the landlord-tenant issue that Senator Lyons mentioned become challenges to scaling this resource. So that's why we're working with the legislature on those issues. For the purposes of this bill, I think the intent, and I hope Senator Lyons, you'll correct me if I've misunderstood this, but I think the intent is to look at this landscape, see how we can make it more vibrant, make sure that we're ensuring quality through these standards, that we're incentivizing certification, and that we're measuring the success of these programs and working with programs that might be struggling in certain areas. So currently, there's not a really good data collection system. So partnering with a Fletcher group to do that study, come up with a common set of data metrics and collection methods could be a really wonderful outcome. And naturally updating the Downstreet Housing Report so we can reprioritize how we make sure that this type of offering is geographically distributed equitably. There's some real holes in the state. We're making progress with that with the homes opening in Bennington. But we have challenges around geographic representation and individual representation. And what I mean by that is we have no type of home that serves the LGBTQ plus population. Certainly someone could enter the existing homes, but I think we could really benefit from a home that specializes in serving that particular population. So with that, I think I'll pause and see if that's prompted any additional questions.
Keep you good, take it. Thank you. This is really helpful because it gets at some of the issues that are not in the bill and that could be, that could improve the bill. My question for you is, will you be interested in participating in the process with the Department of Health and the Chief Prevention Officer going forward and Fletcher Group?
Absolutely. You can count on us to be an active partner and to do whatever the group determines to meet the intent of the legislation. We've been in conversations with Rachel Nichols at the Fletcher Group, and we're excited to continue to partner with them. They're real leaders in this area. For folks that don't know, the Fletcher Group is funded through a HRSA grant, similar to the CORA program at UVM, but they specialize in helping rural communities provide recovery residences with quality in mind. So we would love the opportunity to partner with them on this. And in fact, they shared at the NAR conference a similar effort that they've done in West Virginia. And I think for them, now they kind of have a template that they'd like to offer to all of the states to advance this work. So we may even get some really nice comparables across the country as we do this work.
Okay, thank you. That's helpful. Other questions, committee, for Jeff? Great, thank you. So in my closed door meeting yesterday with Kelly Dougherty and Chief Prevention Officer Hutt, we had a conversation about the bill and what we might do to improve it. Some of the comments that you brought to us, Jeff, are exactly the questions that I was asking and that we discussed. So Deputy Commissioner Dougherty, welcome, and we'll listen to your testimony.
Thank you, Madam Chair. So thank you, Jeff. That was a great overview of the NAR standards. And so I think where we are is next steps. So the intent, we really, like Jeff said, want to sort of codify this certification process, you know, with the aim of quality recovery residences. So I think where we're going with next steps is to sort of beef up the bill to include sort of the mechanism, you know, put a little bit more detail about how the certification process works, who oversees it, you know, what are the eligibility criteria for certification. And then also when Monica Hutt, Chief Prevention Officer, and I were in testimony previously on this bill, she shared the draft charge for the work with the Fletcher Group. So that will really lay the groundwork for kind of getting our arms around the landscape of the recovery residences in Vermont. And also, to what Jeff said, you know, looking at what are possible sort of data collection mechanisms that we can utilize to start looking at, you know, quality metrics, outcome metrics, and those kinds of things. So we would like to put into the bill sort of that work that we're going to be doing around sort of the inventory of recovery residences, and also sort of laying the groundwork to be able to evaluate the successes of recovery residences at the different levels. So what we will do in collaboration with Jeff is to sort of add more meat, put more meat on the bones of this bill and get it back to the committee for review.
That would be terrific. That would be very helpful. And I know that Katie is very much interested in working with you to make that happen. That would be good. So Senator Hardy has a question.
Thanks. Deputy Commissioner, thanks. I'm wondering, given the addition, well, given the bill in general and the additions, and knowing the situation with your division, do you have the resources to do this?
Yes, actually, you know, the bulk of the work actually happens in Jeff's shop to do the certification and oversee the recovery residences. So, and we already work closely with VTAR. And then, you know, the work going forward with the Fletcher Group, you know, they have funding and resources to undertake those endeavors. So we're not concerned about resources for this particular bill.
Okay, that is good to hear. Thank you.
Senator.
Is there enough runway left to get this bill out for?
Yeah. And having the conversation yesterday was extremely helpful. because what was missing with the mechanics, the specificity that we can now have Katie draft once she gets it from folks.
Yeah.
I will raise an issue that we may want to consider, and that is that we currently have an opioid settlement fund, which is coming in on a regular basis over the next several years. And my question is this, there's a lot of work that will go on for, sort of basic. I'm actually asking the question, is there a lot of work that will go on for improvements to IT, to fit up in terms of capital investments that would be sort of bottom floor? Because my concern about the opioid settlement fund has always been that it gets too involved in operation. It may get too involved in operational expenses, and then when the money's gone, we're left to cover it. But my question is, and this is can we make a recommendation to the opioid settlement advisory committee about putting together a separate fund or a set amount of, I think, of $500,000 that can be used for helping some of these recovery centers or homes become established in places where they currently are not existing. So that's a question for the committee to consider. And I know that Senator Hardy is on that advisory committee. It would simply be a suggestion to the advisory committee to consider in the next round. So it would be, and I have, I've mentioned this before, but I think if we have those monies, as we hear from our recovery centers, maybe there is something very basic capital investment that can be used by some of the recovery centers. And so it's a question for Jeff and Deputy Commissioner Dougherty as well, but I think this committee has to decide. We're not directing the use of the money, but we're making a suggestion that might be helpful.
I don't think it's necessary to do that, for a couple of reasons. One, because ultimately how the monies are spent are up to the legislature. So we would just be directing or requesting that the advisory committee advise us to do that.
To do
So
it.
it seems a little circular.
So, yeah, I understand that.
And we did hear from Jeff and the recovery centers, and what they requested was really very small and minimal. So I think part of it is getting the appropriate and request to the advisory committee from the recovery residences.
Right.
Or from the department. I mean, I think that, certainly Deputy Commissioner Dougherty and her team can put together a proposal and bring it to the advisory committee.
Well, I understand that, and I did reach out to Commissioner Levine about this, and because I wanted to know, do the guidelines support it? I couldn't remember, I read the guidelines, but I couldn't remember whether the guidelines supported establishing a fund. So, which is a new and unique, I think it's different from what the advisory committee has recommended. So I would like us to consider that before preempting it automatically and saying, let's not do it. I'd like to consider that based on the testimony that we hear regarding what are the needs for some of the recovery centers. And I know that, Jeff, you also sent us your budget request, which we're not looking at right now. But there may be some value in at least talking about it, so.
Okay. I don't think you can create a fund out of the fund. I think that the money's.
Well, no, the guidelines allow for that money to be held for a specific use, can do it. So.
But putting it into a separate special fund, is that what you're talking about?
I don't know how it would happen. I do know there could be $500,000 reserved on a yearly basis for purposes of, that is what I understand to be allowed.
Oh, yeah, that's just appropriate. You're not suggesting creating another special fund.
Yeah, I'm not
That
suggesting creating another special fund. That probably wouldn't go very far down the hall. But it would just simply be to say, this may be important as we roll out recovery centers in maybe underserved areas. Now, that could be one way of looking at it, but I don't know that we would make that definition in here. Let's think about how we can make that suggestion if we want to. So essentially,
So for Mr. Morale, like what you said about what we have in Rutland being level 4, between 4 and 5. Senator Weeks and I have been involved with a couple different organizations in Rutland, but we didn't know that they were under NAR, number 1, if they are. Number 2, it's the system I've seen there is kind of disjointed. It's a house here and a house there, and a storefront that's been converted to a center turning point. Is there any possibility that any of that funding could be used for, like, to build one facility?
The idea of a larger facility is something that the Fletcher Group really specializes in, and it's a great opportunity for Vermont. I remember Attorney General T.J. Donovan saying to me when I first came on board, there's all these college university properties that are possibly becoming available. Could we not take a facility like that and really create a strong recovery community? So I do think there's certainly an opportunity to do that, and they understand the funding mechanisms to bring all that together. What we have now, you're absolutely right, tends to be small home-like settings, and that's very common with recovery residences. And there is some debate in terms of which is more effective, a facility that is small or a facility that has a lot of people. I think one of the things that I know for a fact is Vermont Foundation of Recovery has scaled across the state. They're insistent that they are co-located next to a recovery center and close by, so that they have those supports, that they're located near employment and the broader community. We've actually had some facilities that have been seized by the federal government that they've offered to us for free. But when they're out in the woods somewhere, they just don't have the supports that you're talking about. So the model now is very conscientious of that.
I like the community-based part of it, but I know that they're always looking for money. I mean, they're operating on a shoestring, a lot of volunteer work. Yeah, thank you for all that.
If I could, just real quickly to say that our approach this year has been to shore up the foundation of current certified recovery residence providers. So that's why we asked the Opiate Settlement Committee for funding for scholarships to help individuals. We asked the state for an increase to the base budget to operate these homes. As just was mentioned, state funding only covers about 50% of the cost to run the recovery residences. Everything else is either done on a shoestring budget or out asking for money through fundraising, and that takes away from the mission work. So we want to shore up that foundation, and I think Vermont Foundation of Recovery is best able to move forward, and their goal is to have a recovery residence in every community that has a recovery center. We're ways away from that, but that seems like a doable goal, but they can't do it until we shore that up and deal with the landlord-tenant piece. In terms of a long-term vision that I think is being suggested here, there is HUD funding that comes to the state on an annual basis for the bricks and mortar piece of this. And so having some funds to maybe match that would make sense. And also funds for the data collection. I think a no-brainer investment would be to offer recovery residences a common resident management platform. And we've been looking at Behave Health as that platform where participants will be able to access their bill right on their phone, any communication, any meetings they have to attend, all that they access from their phone. The operators have a dashboard so they can manage all the intakes and all that information. As the certifying body, we get data that's collected not individual, but as a home, and we can monitor that. And that will allow us to collect consistent data across certified homes. And if we were to turn that switch on today, it would cost $40,000 to be able to provide that to all the certified homes. So it's not a big investment. And if there were a way to do that and do it as we start the data collection that we want to do with the Fletcher Group, that would just make so much sense. It would also incentivize certification. So we do have a number of operators that for whatever reason have decided not to become certified. And the funding through scholarships, being able to provide technical assistance, offering this common resident management platform, all those sort of things will encourage people to come on board. So that's kind of our vision going forward.
So, can I make one more thing?
Yep.
So just one last thing that my point about brick and mortar and was to move it away from the source of the addiction in a lot of cases. So that would be the only advantage. I like it community based. They seem to like the home setting for sure. Anyway, thank you.
No,
Thank you for that.
Yeah, and so what you were talking about with IT at the end was exactly the type of capital investment that I was thinking about when I suggested holding, funds, holding money within the opioid settlement, because it does fit with that. So, so what I'm gonna suggest right now is, unless there are additional questions, and Katie's gonna work with folks to bring some new language that is more mechanistic and specific, and we will, we'll see that when we see it. And so I want to thank both of you for being here this morning. I think this has been a really great conversation and will help move the bill in the right direction. So appreciate it greatly.
Thank you very much.
Yeah, no, thank you. So what we're going to do now, Kiki, we'll go off live and we're going to take